Now, 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 let's talk about diagnosis of iron deficiency anemia. We approach to the iron deficiency anemia like this. First of all, you will look for the sign and symptoms of iron deficiency anemia. Then you will take the history from the patient, specifically about the duration of sign and symptoms, and you will ask about the GI system. You will ask about any system which is affected by the iron that we talked about them. Then, then you will examine your patient. Okay, you can do some physical examination for the nails, for cheilitis, for glossitis, for restless leg syndrome, and so on. Then in lab you you will interpret CBC report. Okay, you can give the CBC for the patient, and you then read and interpret CBC. After the CBC, in CBC you will find less hemoglobin, less RBC, less MCV, less MCH, less MCHC, more RDV, and so on, that we talked about all of them. And then you will give iron profile test, and in iron profile, this is iron profile, an iron profile test, you will find the type of iron deficiency, the type of iron deficiency anemia, and so on. And then you will find the severity of iron deficiency anemia, that this patient is in which stage of iron deficiency anemia, in mild, moderate, or severe. And then this is the most important part: differential diagnose the iron deficiency anemia with these conditions that we will talk about them. And after the differential diagnosis, now you can treat your iron deficiency anemia, and then treat the causes of iron deficiency anemia. So now let's talk about the differential diagnosis of iron deficiency anemia. Sorry, there was a bit problem in this chart. I made it again, but anyway, let's compare iron deficiency anemia with thalassemia, with anemia of chronic disease or inflammatory disease, with sideroblastic anemia and lead poisoning, because in all these situations you will find less hemoglobin, you will find microcytic anemia, and sometimes you will find hypochromic anemia. So that's why you have to differential diagnose iron deficiency anemia with these conditions. Let's start it. First, about the ferritin. In iron deficiency anemia, ferritin storage drops because I don't have enough ferritin in my body. In thalassemia, problem is with hemoglobin synthesis. I cannot make correct type of hemoglobin. For example, in adult we have hemoglobin which has 2 alpha and 2 beta chains. For example, I cannot make a beta chain which transports enough oxygen to the body. So, for the compensatory mechanism, bone marrow tries to produce a lot of new RBCs and incorrect types of RBCs with incorrect types of hemoglobins. So, the size of RBC decreases. Okay, so that's why here the problem is not with iron. So, the ferritin will be normal, or it will be more inside our body. Okay, plus in anemia of chronic disease, here also problem is not with ferritin, because I have storage of ferritin but I cannot use it, so it might be normal or high. In cerebroplastic anemia, the problem is with the using of iron. I have enough iron, I have enough ferritin, but I cannot use it to make hemoglobin. I cannot use it to join it with hemoglobin. We will talk about these diseases in upcoming lectures. So here also the ferritin level might be normal or a bit high. With lead poisoning, here most of the time it it's normal. In lead poisoning also, I cannot use hemoglobin for the forming of I cannot use iron for the forming of hemoglobin. Got it? So now come about the bone marrow iron. Here in iron deficiency anemia, I don't have enough iron in bone marrow. In thalassemia, because problem is not with iron, so it's normal. Okay, or sometimes it might be more. In anemia of chronic disease, here most of the time it is normal, or it might be a bit less, because here also the problem is not so much with iron deficiency. Here the problem is in recycling. Got it? Now in cerebroplastic anemia, the here it increases a bit the ferritin the what bone marrow iron, because a lot of iron comes to the bone marrow, and they will not be used by hemoglobin synthesis, so they accumulate inside the bone marrow, and in lead poisoning also it increases a bit. Got it? About the serum iron, so in iron deficiency anemia I don't have enough iron, so it decreases, serum iron decreases. In thalassemia, it's normal. I don't have any problem with iron. And anemia of iron deficiency anemia, it also decreases, because I don't have enough iron to transport it from one part of the body to the other part of the body, and because I cannot release it from the macrophages, I cannot absorb it from the gastrointestinal system. With sideroblastic anemia, there is no problem with serum iron. In lead poisoning also, because there is problem in bone marrow, we cannot use iron in bone marrow. So come here to the total iron binding capacity. My transferrin receptors are hungry for taking of iron. Okay. So I have a lot of total, I have a lot of transferrin here that they're empty, so total iron binding capacity increases in iron deficiency anemia. In thalassemia, it is normal, or it decreases, because I don't want enough a lot of iron. Okay, so in anemia of inflammatory disease, okay, here total iron binding capacity sometime it might be normal, or sometime it, but most of the time it might be normal, because I don't have I don't need a lot of iron. Okay, bone marrow is not stimulated so much. Here in sideroblastic anemia, no problem with the total iron binding capacity. About the transferrin saturation, here because I don't have enough iron in serum, so transferrin will not be saturated enough in iron deficiency anemia. In thalassemia, no problem. In anemia of iron deficiency anemia, it also decreases, because I don't have enough iron inside the circulation. And cytoblastic is normal, and lead poisoning it's not. I don't have a problem with these things. Here about the transferrin saturation, because in iron deficiency anemia we have a lot of transferrin saturation. We have a lot of transferrin receptors on the surface of RBC. So a lot of transferrin receptors are shedding into the circulation. So it increases. It increases. In thalassemia, there is no problem with the receptors with the iron, so it's normal. And anemia of chronic disease, it's most of the time it's normal, or sometimes it will be increase a bit. In sideroblastic anemia, no problem. Here also no problem. Or these most of the time decreases in these last two situations. About the hepcidin, this is an inflammatory protein in iron deficiency anemia. It decreases because, and during iron deficiency anemia, bone marrow wants a lot of iron, so it suppresses production of hepcidin, so it decreases. But in thalassemia, there is no problem with hepcidin. In anemia of chronic disease, there is a lot of hepcidin. I have a lot of hepcidin that inhibits the absorption and recycling of iron. In sideroblastic anemia, I don't have problem, and it most of the time it will be normal or less. And lead poisoning, it will be normal or less. Come here, HB, because all of them are anemia. So HB or hemoglobin goes down in all of these situations. I'll have less HB, I'll have less HB here, I'll have less HB here, I'll have less HB here. In all of them are anemia. It's easy. About RBC count. Here in iron deficiency anemia, it decreases because I cannot produce enough RBC, because I don't have enough iron. I cannot make enough hemoglobin. In thalassemia, it might be most of the time it might be normal. Okay, in anemia of chronic disease, it also it might be normal, or it decreases. In cerebroplastic anemia, it might be normal, or sometimes it this, and also here is no problem with this. Come here with MCV, main corpuscular volume. This is very important. In iron deficiency anemia, main corpuscular volume decreases, the size of RBC decreases. In thalassemia, it decreases more than the iron deficiency anemia. The here size will be more smaller than the iron deficiency anemia. We will look at later on. In anemia of chronic disease, most of the time the size will be normal or smaller. Okay, placid sideroblastic anemia, I don't have a problem with. Here also, most of the time it was might be normal or decrease. In lead poisoning, normal or decrease, because in all of this situation we cannot use iron. When we cannot use iron, we cannot make proper hemoglobin, so size most of the time decreases. Now about mean corpuscular hemoglobin, or MCH. Here in iron deficiency anemia, we cannot produce enough hemoglobin, so it decreases mean corpuscular hemoglobin. In thalassemia, okay, in thalassemia, listen me carefully. In thalassemia, inside the RBC, we have hemoglobin, but this hemoglobin is not functionally correct. Okay, so here most of the time it decreases or it might be normal. In anemia of chronic disease, it also decreases or it might be sometime normal. In sideroblastic anemia, it decreases because I cannot make hemoglobin. In lead poisoning, it decreases. Come here about the MCHC, main about this one. Okay, about the concentration of hemoglobin inside the RBC. Here it decreases because I don't have enough uh, hemoglobin. In thalassemia, it's always normal because I can make enough hemoglobin, but this hemoglobin is not functionally correct. In anemia of iron deficiency anemia, it might be normal or less. In sideroblastic anemia, and also in lead poisoning, it about the RDV. Here in iron deficiency anemia, are decreased because some RBC are smaller, some are larger. In thalassemia, it's normal, okay, because the most problem is here with hemoglobin synthesis functionally, not structurally. In anemia of iron deficiency anemia, it's sometimes it increases a bit. In sideroblastic anemia, it increases, and also in lead poisoning, it increases because some cells are smaller and some are larger. Got it? About the reticulocyte in iron deficiency anemia, it decreases because I don't have enough iron. In thalassemia, it's normal. In anemia of iron deficiency anemia, it's normal, or sometimes it's increasing a bit. And sideroblastic anemia, there is no problem with reticulocyte. About the platelets in iron deficiency anemia is increasing because we stimulate bone marrow simultaneously. Okay, here in thalassemia, it's normal. In anemia of chronic disease, there's no problem with this. In sideroblastic anemia, no problem, and no problem. Clinically, iron deficiency anemia have signs and symptoms of iron deficiency anemia, and thalassemia signs and symptoms of thalassemia. Anemia of inflammation, here you will have signs and symptoms of inflammation. In sideroblastic anemia, you will have signs and symptoms of anemia, and in lead poisoning, you will have some signs and symptoms related to GI and nervous system, which are related to the lead poisoning. So they are separate lectures. Okay. Here is one point about Menser index. It means when we divide mean corpuscular volume on RBC counts in millions. For example, mean corpuscular volume is around 70 femtoliter. When we divide it on RBC counts, for example, RBC counts are around 4.5 million or 5 millions. So the result which comes out, if it's greater than 13, so it's most of the time it's thought to be iron deficiency anemia. So more than 13, okay, more than 30. Got it? And here in thalassemia, it will be less than 13, and we don't use them there. Okay. About the CRP in iron deficiency anemia, there is normal because there is no inflammation. Thalassemia, it's normal, we don't use it. In anemia of inflammation, it might be it's thought to be increased. Okay, and in cerebrovascular anemia we don't use them. So these were the differential diagnosis between these types. When we study about each of them one by one, you will learn them step by step. Now let's talk about the treatment of iron deficiency anemia. Now, how to treat iron deficiency anemia? First of all, you have to choose the way of your treatment. Okay, for example, this treatment is up to date, okay, related to now. The first line treatment for the most of mild and moderate cases plus in first and second trimester of pregnancy is oral iron or oral therapy. Okay, because it's much more studied and also it has less side effects and it's more usable way. Now we have different types of oral iron. Okay, for example, I'll tell you some differences between or among them, and you have to study the pharmacology of them. But anyway, one type of oral iron is called ferrous ferrous sulfate. Okay, ferrous sulfate contains around 65 to 100 milligram elemental iron. What do I mean by elemental iron? It means, for example, if you take a tablet of 325 milligrams of ferrous sulfate, okay, you will have 65 milligrams of iron inside this 325 milligram tablet, and other parts other than 65 milligram, other parts will be the extra part of this tablet that they're not iron. They're using for absorption of the tablet, for giving the shape of the tablet. So I'm talking about elemental iron. It means core iron in your tablet. So in ferrous sulfate, the core iron is around 65 to 100 milligrams. Okay, so this is the cheapest iron. It's more studied iron. It's more available iron. Okay, it's more usable iron by the doctors in clinic. Okay, the second type is ferrous fumarate. Here we have more iron in one tablet. The elemental iron might be around 105 milligrams, or from 30 to 105 milligrams. It has more iron, and it's a good alternative drug for the ferrous sulfate, because the side effect of ferrous sulfate is that it causes GI upset. It can cause diarrhea. It can cause nausea, vomiting, constipation, different side effects related to GI. Okay, next one is ferrous gluconate. This has less iron, less elemental iron, around 27 to 38 milligrams, but it is good tolerated. Okay, it's slow released iron. Another one is saccharosomal iron, which has less iron, 30 milligram, but it is good tolerated with less GI side effects. Okay, another one is ferric maltol. This also oral tablet, and it has 30 milligram iron, and it's also good tolerated. It's very good in absorption, but it's used most of the time in inflammatory bowel disease. Okay, about ferric citrate, it's most of the time used by the doctors in chronic kidney disease because it decreases the sulfate, it decreases the phosphate in the blood also. It's the benefit of ferric citrate. And its dosage is, its elemental iron is from 45 to 200 milligrams per tablet, depends on different tablets. About iron polysaccharide, the elemental iron will be from 50 to 200 milligrams per ml. Okay, and it's good absorbable, and most of the time this is used by the doctors in children. So now when you give oral iron for a patient, you have to give around 65 to 100 milligram dose per day, or in new guideline they say that give the oral tablets in alternative days. Okay, one day after another, because when you give it every day it causes more production of hepcidin, which prevents from the iron absorption. But when you give it in alternative day, the net result will be same, but the GI upset and hepcidin production will be less. This is the benefit. Okay, so give it with an empty stomach. It means that the distance between food and taking of tablet should be around 1 up to 2 hours. Okay, and take it with vitamin C, because food, tea fights these things, inhibits iron absorption. Got it? And then when you, I'll talk about it at the end. Okay, now this one point. Now sometimes we prefer IV iron. Okay, it means in which situation we give parenteral or IV iron. First, when iron oral iron is not tolerated by the patient. Okay, or if a patient has, for example, inflammatory bowel disease. Okay, so plus if we give a high dose, a large dose for a patient. Okay, if a patient is in severe anemia, so in these situations we give IV iron. Okay, so one of the most dangerous side effect of IV iron is anaphylaxis. Okay, if you give this iron, so it can cause anaphylactic shock. But newer generation of irons, they produce less anaphylaxis. They're so much safe, and chances of anaphylaxis is less than 1%. Got it? So, but still, doctors do the test dose before giving IV. They give around 20 to 25 milligram of iron, dilute it in 20 to 25 ml. They give it around 10 to 15 minutes, and they wait for 10 for the patient around 10 to 15 minutes, and then they start. If there is no allergic reaction, they start the IV dose. Plus, when you give IV injection or IV iron, you have to have all stuff of anaphylactic shock, for example, adrenaline and so on. You should be ready for the allergy. Got it? So now, how to calculate the dose for the IV iron? Most of the time, the dose will be around 1 up to 1.5 gram. So, based on Gain-Zani formula, you can calculate it that you take the body weight of the patient, you multiply it by the target HB minus patient HB. For example, you have to reach hemoglobin of your patient up to 13, okay, so now your patient hemoglobin is around 9 or 10, so from 13 minus 9. Okay, so then the result will be, for example, 2. So 2 times body weight times 2.3, this is constant, plus 500. So in a net result it will be around 1 gram up to 1.5 gram, or 1000 milligrams up to 1 up to 1500. Got it? So now we have different forms of IV. One of the most usable form is iron sucrose. Okay, the single dose is from 200 to 300 milligrams. Okay, dilute it in 100 to 250 ml of normal saline, and give it in slow infusion in more than 30 minutes. Okay, plus the second type of iron is ferric carboxymaltose. When you want to give us a large dose for your patient and 1 or up to 2 dose, so it's around 750 to 1000 milligram in one dose. Dilute it and give it to the patient. Okay, about the iron dextron, this iron dextron is the oldest one. You need to give a test dose, and you need to give it to your patient a very slow infusion in more than 4 hours. This is the new one, ferromoxitol. It's given around 30 milligram per kg, but you can give 510 milligrams in one dose, and specifically it's usable in chronic kidney disease. But anyway, now note, be ready for allergy. Okay, give them slow IV iron. About the follow-up, follow your patient, specifically this oral in oral therapy. If after 2 weeks or 2 up to 4 weeks, the hemoglobin does not rise more than 2 grams per deciliter, so it means more than 1 up to 2 grams per deciliter, it means your treatment is failed. Got it? So search for the cause and treat it again. Got it? And if plus here you can give some supportive therapy during the iron therapy. You can give vitamins, folic acid. And there are some companies that they make all of them in one tablet, for example fefulvate, for example sangobion, hybrid folate. And this structure we have vitamins plus elemental iron plus vitamin C, and so on. Got it? So the first way to treat your patient is oral therapy. The second way to treat your patient is IV therapy. The third way to treat your patient is give the blood donation. Okay, so this blood donation is in severe cases and in emergency cases. Got it? So in toxicity of iron, there is a drug that's called defloxamine, and it can be prepared specifically during the thalassemia. We'll talk about it during the thalassemia. So these are all about the iron deficiency anemia. Now you can treat your patient safely, you can diagnose it perfectly, and these were all about iron deficiency anemia. Have a good time.